The main event at the HFA 2021 Congress has been the presentation or the peak preview of the ESC HFA guidelines on heart failure. Of course, they covered the main treatment and the main treatment pathways for heart failure, but also specific focus for those patients at increased risk of heart failure and patients with an ischemic origin. Also, during the Congress, there's been a clear presentation of the patient profiling position paper of the Heart Failure Association. This patient profiling paper basically depicts and gives guidance on how guidelines should be implemented in clinical practice. This is very relevant for patients with angina, because for patients with ischemic heart disease, with heart failure, or patients with ischemic heart disease at increased risk of heart failure, then there is, of course, a need to be treated differently. Now, we note, for example, that in patients with heart failure, we can tolerate a blood pressure down to 90 millimeters of mercury systolic. That is different for patients with ischemic heart disease, where we shouldn't exceed blood pressure lowering. We should get not lower than 120 millimeters of mercury systolic, not lower than 70 millimeters of mercury diastolic. Now, this has very profound implications because most of the medications that we use in heart failure have a significant effect on blood pressure. So ACE inhibitors, MRAs, and beta blockers, diuretics. And therefore, we need to understand how best use these drugs. Of course, we have the SGLT2 inhibitors. They are the new kids on the block, and they have a neutral effect on both heart rate and blood pressure, therefore should be always implemented in clinical practice whenever possible. As regard to the ACE inhibitors and beta blockers, we know that ACE inhibitors are very protective, even for future cardiovascular events. And we know from data from different trials conducted with ACE inhibitors that we have a gradual effect, of course, according to whether there's a prevalence of heart failure or prevalence of ischemic heart disease. But for ischemic heart disease, there is clear evidence that perindopril is more protective for coronary arteries than the other ACE inhibitors. Now, when we go down to heart rate reduction, that is very important because heart rate reduction with beta blockers is associated with a significant reduction in blood pressure. Therefore, we want to achieve an optimal reduction of heart rate, but coupled with a decent blood pressure. Otherwise, if we lower blood pressure too much, we increase the risk of future events because we reduce coronary perfusion. And therefore, the use of drugs like ivabradine and trimetazidine become very central. Trimetazidine is extremely effective for angina, but also has a very important effect in patients with left ventricular dysfunction. This has already been recognized by the 2016 guidelines, by clinical trials and studies that have demonstrated an effect on left ventricular function, exercise capacity, quality of life, and also by pooled analysis of clinical trials that have shown an increased survival. So trimetazidine should be always implemented in clinical practice in all patients with heart failure and ischemic heart disease or patients with heart failure of ischemic origin. The other point is the use of ivabradine, and this is very central for patients with heart failure because ivabradine will enable the use of other medications whilst reducing and keeping at the minimal dose of a beta blocker. Therefore, the combination of ivabradine and beta blocker has a synergic effect, as an anti-ischemic, as demonstrated by the ASSOCIATE study, has an important effect on mortality, as shown by the SIGNIFY study, has also important effect on exercise capacity, as demonstrated by the CAVIVA study. In this regard, it has been clearly shown that if you give ivabradine plus a beta blocker, then there is a greater exercise capacity than doubling the dose of a beta blocker. Therefore, it is clear that the new path for treatment of patients with ischemic heart disease would be to use drugs that reduce the degree of ischemia, but also reduce events in heart failure. Therefore, we need to implement SGLT2 inhibitors, ACE inhibitors, when possible MRAs, and learn to use how to implement
beta blockers and ivabradine together, and implement always trimetazidine, because in this way we will provide patients a significant effect on quality of life, on exercise, and we will improve prognosis.